I'll leave with you, mate.
Thank you. So a little bit more about improving pain and function in people with painful degenerative knees. As Peter said, I'm based out of Wakefield Orthopaedic Clinic, having completed university in Adelaide and then subsequently orthopaedic training in WA. I travelled overseas for further advanced orthopaedic training, mostly for hip, knee and shoulder sports type surgery, and also completed the first robotic assisted surgery fellowship in Australia in 2016 in Perth, now based back in Adelaide, of course. So a bit about my experience with patients, and most patients will say, why does my knee hurt? And often it's described invariably as an ache, hard to localise often, maybe across the whole knee. Some patients do have what we call the single finger sign, where they can point to one point on their knee that is sore, but often it is across the whole knee. Often it's described as a toothache-like pain, possibly burning, sometimes spasms in the front and the back of the knee. Generally, activity-related pain is a major complaint because it's really starting to affect your quality of life when it's stopping you from doing the things you enjoy, going out for walks, seeing people, seeing your friends. For some people, they have to stop working because of their joint pain. And once it starts to affect sleep at night time, I think that's really when things turn the corner and life becomes more challenging. A lot of patients will say to me, why have I suddenly got arthritis? I knew nothing about my knee arthritis until I saw you. Why have I got knee arthritis now? And it's not so much that the arthritis has suddenly come on, because arthritis is a progressive degenerative condition. And so in most people, it's a condition which occurs with years of experience. So the more years through the knee, and potentially the more injuries through the knee, the more likely you are to have knee arthritis. And so this is a diagram of a knee, which is looking nice and healthy in this diagram. Nice, smooth, hard, white cartilage, intact cushions, which are called the meniscus. These do wear out the same way that hard cartilage wears out. So I liken the hard cartilage to the gristle, and this is the soft gristle, the meniscus. This is a healthy looking knee with good muscle bulk in the quadriceps. There's no swelling about the knee, and healthy looking calves. So this is a knee that's working well. This person's able to do their day-to-day activities without great limitation. And for some reason, they've had an MRI scan which shows a perfect knee. There's good intact hard cartilage, which is the grey colour here. There is a nice black triangle called the meniscus here, and another one on the inside of the knee. This is the MCL, one of the ligaments. These are the two internal ligaments called the ACL and the PCL, and these are the lateral ligaments here. So this is a healthy, normal knee. And then underneath, we've got a worn-out knee. So it's got advanced osteoarthritis, these sort of ulcerations in the hard cartilage, which we see when we look directly at the knee at operation. The meniscus itself, the nice cushions inside the knee, they're either destroyed completely or they've been extruded from the joint. So they start to push out into the MCL and the lateral collateral. When we look at the knee, we're starting to see some deformity. There's a change to the shape of the leg. There's some swelling, so you can't really identify where the kneecap is anymore. The calf looks atrophied or the muscles have lost their bulk. And same with the quadriceps up the top. And this is the MRI scan. Now we don't have any nice black triangle meniscus inside the medial compartment. This is all white now, which is fluid. So this side of the knee here has completely lost its hard cartilage. There's no grey on top of the black bone. And so this is bone-on-bone arthritis in that side of the knee. On the other side of the knee, the meniscus is still there. So this patient's actually had a knee arthroscopy at an earlier time in their life. They've had meniscal tearing, either traumatically or as part of their degeneration, and they've had that meniscus taken out. This cartilage is worn out, and this is why they're getting their knee pain. So you don't just turn from one night to the next, from this to this. This is a progressive degenerative condition, cumulative damage over your life, and then you start to generate pain. What we don't see, what I can't tell you, is how much pain this person is in. That's a very individual experience, and everyone, their knees, as they degenerate, behave in a different way. The other common complaint or report is about knee swelling. Really, knee swelling is the body's attempt to nourish and protect the joint in a joint that's less than perfect. So you don't have the normal cushions, the meniscus, working well. You don't have the normal hard cartilage providing friction-free movement within the joint. And so the body tries to lubricate and protect with excessive joint fluid. And that's when you start to get swelling. Often people will describe their swelling up the top of their knee. Actually, the knee joint itself is one continuous space. And so that fluid will roll around from in between the thigh bone and the shin bone, in between the kneecap and the thigh bone, and also up in this space up here, which is called the suprapatellar pouch. And so the fluid collects up there, and that's where we can most easily see it. And on the knee, on the left side of that picture, you can't really make out the kneecap anymore. The swelling's really puffed up, and it's looking very swollen. That swelling can come and go. You might have good days and bad, just like the pain. And eventually it may result in a Baker's cyst. And this is a cyst in the back of the knee. Patients will often come to me and tell me their problem is their Baker's cyst. But I try to describe to them that the Baker's cyst is really the tip of the iceberg. And often it's because the meniscus and the hard cartilage experiencing degeneration within the knee that causes the Baker's cyst to fill with the fluid from the joint itself. So what is going to make my arthritic, painful knee better? And Karthik's outlined that beautifully tonight. Really what we call a multimodal approach to arthritis. So trying as many different things so that we can create a personalised program for each patient. There are some key factors to that, and part of that is pain relief. And Panadol Osteo still is our main pain reliever, basically because it's cheap, readily available, and has a low side effect profile. Whereas many of the other medications, such as codeines, Panadine Forte, create constipation, dependence, and have reducing effect over time. So you're needing higher doses. So we try and avoid the strong painkillers at all costs. Additionally, we use anti-inflammatories, and really, as Karthik has said, anti-inflammatories have become the first-line treatment for many of our patients with arthritis. Sometimes the swelling relief can be achieved with a supportive brace for short periods. So it might just be a brace that is flexible, but provides a bit of support just to stop the kneecap from lifting off the front of the knee, because that's when you start to lose the feeling of control in the knee. And then some of the gels, so the Voltaren gels, Flexor rubs, a lot of patients really enjoy those, and so they get relief, particularly at night time when they're trying to sleep. I, like Karthik, have a strong relationship with the physio teams, because really all of my patients with early and moderate arthritis are going and doing a physio program to try and improve the strength across their pelvis, their hips and their knee. And we know that gives them a relief of their pain and improved function. So it's a really important part of the trial of therapy that we're doing before going to the next line. And part of that is reducing the load. So as Karthik mentioned, weight loss is really important, but also the modification of activities. Some people don't want to modify their activities. They really want to maintain their lifestyle exactly as it is. But sometimes a challenge of reducing the activities that give them pain may actually improve the longevity of the knee that they've got. And ultimately, when I get involved, it's about joint replacement. So a little bit more about joint replacement. Most people will have heard of knee replacement surgery, perhaps had one themselves or had a friend who has. And just briefly, a knee replacement is the resurfacing of the worn out surfaces in the knee joint. The picture on the right shows a total knee replacement. So that this is the cap that's placed onto the femur once the arthritic bone surfaces are taken away. This is the plate that sits on top of the shin bone. This is a fin that sits inside the bone. And this is the plastic or polyethylene liner that articulates with or joins onto the femoral component and creates very low friction movement. This procedure is performed to reduce knee pain and improve function in patients with arthritis and degeneration within their knee. The aim of the operation is really to assist you in being able to return back to the things you enjoy without pain. This is a picture of us at Calvary Adelaide Hospital. This is the team we have performing Mako robotic assisted surgery at Calvary Adelaide as part of the Wakefield Orthopaedic Clinic. Just a little bit how surgery is performed. So in my operating room, we generally try and perform the majority of the surgeries under a spinal block. This is to give good pain relief after the procedure as well as during. And we combine that with local anaesthetic into the tissues around the knee to give you, again, longer pain relief after the procedure is done. Once the spinal anaesthetic and the local wears off in a slow way, we can keep on top of the pain with tablets on the ward with the nurses. The surgery is done through an incision at the front of the knee. We move the kneecap out of the way and then remove the arthritis from the knee joint. And this can be done in one of many different ways. I'll mention that in a moment. The components are then inserted, the wound is closed with dissolving sutures, and then we put some waterproof dressings on to allow ease of rehab afterwards. The surgery is done in many different ways. The four main ways is with conventional instruments. And so you can see that we would apply a rod that goes into the bone. We drill a hole into the end of the bone, put a rod inside, and use jigs attached to that rod to recreate the normal alignment and shape of your knee and your leg. Another way is to use patient-specific jigs. So these are created with 3D printing after taking a CT or an MRI scan of your knee and planning the surgery ahead of time. And the other way is with computer assistance or robotic assistance. So this is the Stryker Mako robot. And really this is a high-level execution tool. There's no magic to the robot. It still cuts where I tell it to cut and where I hold it to cut, but it is allowing me to execute my plan to a high level of accuracy, and that's been shown in research. All of these techniques are well recognised, and at Wakefield Orthopaedic Clinic, our surgeons use all of these techniques. What happens after the procedure? So in general terms, my knee replacement patients would stay in hospital for 3 or 4 nights. We would stand and step on the same day of surgery with the physios. Pain relief is started as the spinal and the local anaesthetic starts to wear off. Really important part is actually this part here, which is the laxatives, because the last thing we want is for you to try and go home after a knee replacement and have to come back because you're constipated. So that's an important part. Lots of physiotherapy as an inpatient in hospital, and then back into the community with your physiotherapy team to get the most out of your knee replacement. And so a big focus on strengthening your quadriceps and your hip muscles, the gluteal muscles, and getting back to a normal gait pattern as quickly as possible. So following knee replacement surgery, which is major surgery, it takes time to get to the point where you're happy with your knee replacement. And so to give you a bit of an idea, 3 to 4 nights in hospital, generally by 2 weeks, my patients are quite comfortable mobilising short distances. By 4 weeks, I'd see you driving a car, in the majority of cases. Light work should be possible by 6 weeks, 3 months for the heavy work, including ladders and stairs. By 6 months, most activities are normal. And by 12 months, I'm aiming for you to have a forgotten joint, to the point where you're not really sure which knee would have the knee replacement. You're just quite happy and comfortable with it. Typically, we'd see you at 2, 6, and 12 weeks, and then as needed following that point. Usually we follow you up yearly with x-rays to make sure things are going well. That's it from me. Any questions?
Thank you. Thank you very much. I think that was awesome. I definitely learned a few things myself there, actually. We have had a few questions come through, so just give me a sec whilst I just pull them up. This one's a little bit in-depth, but it's a really good one, so thank you to Theo. Theo says, I've had an ACL reconstruction and 2 meniscus repairs in the same knee. I've had comments made to me that arthritis is more or less guaranteed for me as I age. All operations were done prior to being 19 years old, and I'm now 26. From time to time, I have knee pain in reference to tight quads, but the knee pain is not consistent with my non-operated knee, with equal quad tightness. So it doesn't seem to think it's related to the quads. At what point, as I age, should I be considering getting any scan checkups to assess the health of my meniscus and knee?
Yeah, good question. Really, with anyone that has ongoing knee pain after any sort of injury, there are some key signs that there might be an internal problem with the knee. And really what we're trying to work out is whether your pain and symptoms there are coming from the knee structures itself or from the muscles and tendon units on the outside of the knee. Because once we can come with a diagnosis, then we can target a treatment. So the first thing would be to see one of us and have the knee reviewed and examined. And what we want to find clinically is, have you got full range of motion? Have you got a stable knee when we test the ligaments? Have you got any swelling within the joint? And if any of those things are not as we would expect, then that's a bit of a flag. And it might show that there's an internal problem with the knee. And that's when we would organise a scan to further investigate it. If we're finding that the knee is actually structurally sound, then it might be revising and modifying the physio programming for strength to get you back to full activities.
Awesome, very good.
I would agree. I think when I hear about this, when I would see this type of patient, my first thing would be check their strength. Are they strong in their lower limbs? Is there a weakness around the muscles higher up, so around your hip and pelvis, that are affecting movement patterns that are then causing overload of structures in the knee? So that's where, a good examination will help us kind of investigate further into what's going on. And then if we need to, then scan. But certainly the investigation and patient history is key here.
Beautiful. I definitely agree with that myself. Now, we do have another question, is what age would be acceptable to be looking into a knee replacement? And I know everyone's got a slightly different opinion on this, but for yourselves, what age would you say is too young, and then when is it worth looking into?
Yeah. Do you want to go first?
Well, no, I'll let the surgeon answer this one.
This is a very personal thing. So it's a part of joining the patient journey and the surgeon advice or the doctor's advice and working out what's right for you. There's no perfect answer because you can argue either side of the coin on that one. Really, what you have to do is understand what you're trying to achieve and what the consequences of that treatment is. So once you understand that, then you can choose to do it how you like. The upside of having it treated earlier is that you can regain a more normal lifestyle, less pain, better lifestyle. The trade is, though, that there's a higher chance that you're going to need further surgery on your knee at some stage in the future. Every joint replacement gets put into the joint registry, and we look at how joint replacements perform, not only the implants or how they're implanted, but also the patient characteristics. And so we do know that younger patients are more likely to have a further surgery. And that really goes with, it seems pretty obvious, doesn't it? You've got more years to live, and you've probably got higher expectations of that joint. And so you're going to wear it out earlier. But if you said, that's, I can accept that, what I want is pain-free, good function years now, then it's worth having a conversation and just starting that conversation.
It's very much just that risk versus reward then, isn't it, of looking at where you're at and what you need right now.
Yeah.
Beautiful. Now, we have had another question from Deirdre. I have OA in my left knee. I had an arthroscopy last year. It's now painful, swollen, and my lower leg and my foot are also swollen. Is this normal with an OA flare-up? I've been checked for DVT, but that was clear.
There's likely there was a Baker's cyst there as well. The problem is the knee will continue to create fluid until you take away the fluid generator. And so the arthritis and the inflammation that's occurring in the lining of the knee will continue until arthritis is treated, or at least the inflammation is treated. So often with the swelling that's going down into the calf and into the foot, it's often to do with the Baker's cyst that occasionally then discharges itself out the back of the knee and down into the calf.
Yeah.
Often you'll notice that you can't get your knee as straight as you used to be able to get it, and also you can't flex it as much. So you're starting to get some stiffness as part of that as well. The problem is at arthroscopy or keyhole surgery, there's very little you can do for joint degeneration. You can't put hard cartilage back in the knee in an arthritic knee. You can treat the degenerative meniscal tears, but the indications for arthroscopy in arthritis is becoming less and less. So if you've got a block to your motion, then that's worth having a knee scope for an arthritic knee. But otherwise, you may find that the benefits are short-lasting. And that's what we've seen in the research that's been done on it.
Had an interesting one come through just now as well. Now, this one is, they're a reasonably young person, 22 years old, and they want to know what's better for someone their age who's quite active and plays a lot of sport, a meniscus repair or a meniscectomy?
The decision between the two comes down to the type of tear you've had.
Yeah.
So if it's a discrete single episode tear that's occurred in a part of the meniscus which has blood supply, then it's very likely that it's repairable. But in certain parts of the meniscus, the blood supply is very poor. And so if that tear extends into a poorly vascularized part of the meniscus, then it's unlikely to repair or heal with a repair. And so that's when the decision will be made to trim it rather than repair it.
And the follow-on from that one is, what are the recovery times between, like, what does it differ between those two options?
Generally, when I do a meniscal repair, I'll slow people down a little bit. So it means putting you on crutches probably for 6 weeks. Depending on where the tear is, I might tell you to restrict your range of motion in a certain way for a period, just to give the best chance of that meniscus healing before we put stress through it. Ultimately, the meniscus, like a lot of soft tissue injuries, is pretty well healed by about 3 months. So if we're going to be successful with the repair, it's the first 3 months that's key. And then after that time, it's all about the physiotherapy, the strengthening. Because even with a healed meniscus, if you've got weak quadriceps, weak abductors and weak core, you're going to be symptomatic of the feeling of instability and the feeling of poor function. So it's really important to get back to the physio, even once the meniscus is healed.
No, that's good. And I've just got another screen down here. Another question is, what outcome measures are used in the clinic to determine if a patient should have a total knee reconstruction or replacement, sorry?
Yeah, so we use a range of patient scores.
Yeah.
Really helps us, it helps us inform the condition the knee's in, but it also allows you to remeasure it with time and check what difference we've made with our intervention. Or so that might be, do it on day 0, go and do some have some pain relief, do some physiotherapy, and try some weight loss, and then rescore and see where we're up to. And those scores can help inform the conversation and say, I think we're making some headway into the problem, or I think we're really stalled, let's go to plan B. And then we'll still use those scores after surgery to chart progress.
Yep, definitely. Now, question for Dr. Badranath there, just around the PRP, who's most likely to use that? Is that someone who's maybe like an athlete who money really isn't an issue and they're looking for those 1%ers? Or is that used by people in the general population? Like, what's the sort of split there? Like, who actually goes down that path?
Basically anybody. So it's if our usual treatments have not worked, and as I said before, if the patient is not keen for surgery and they can afford the injection, there's no real limitation on who can have a PRP injection. I mean, it is your own blood going back into your joint. So from that side of it, it's quite safe. There's just the small risk of having an injection in your knee joint. So if we can avoid injection into your knee joints, it's better. But really, there's no kind of limitation on who can have it.
Yeah. Oh, beautiful. And this one is for Luke. Where else besides in the city and at Modbury are you consulting?
So I am also consulting in the western suburbs. So it's down on Port Road in Woodville at Adelaide Medical Solutions. And then my country locations are Narracourt, Mount Gambier and Berry. So central, east and west, and then rural.
Very good, very good. All right, that's all the questions that have come through, guys. Unless you've got anything else you'd like to add in for the people who are watching. We've had about 35 people log on to watch between the two platforms today.
Thank you very much for joining us tonight. It's been great fun. Thanks, Peter.
Thanks for giving this opportunity to us, Peter. We look forward to consulting up there in Modbury.
No, it's been great, guys. And yeah, thank you to everyone who's jumped on. It's been, really informative 45 minutes. what I'll do is I'll post on Facebook afterwards all the details. There's the Facebook Live there. Also, everyone who registered and has come to the webinar, I'll send you a follow-up email just to see how you enjoyed it, and if you want any contact details for either Dr. Luke Mooney or Dr. Karthik Badranath. But thank you very much for coming on, my friends.
Thank you.
Thanks.
We'll catch you later.
Bye-bye.
See you later.